The next talk is to be given by Professor Frier from Edinburgh, Prevention and Treatment of Hypoglycaemia.
Thank you, Simon. Good afternoon, everybody. This is just a brief outline of what I'll say in 10 minutes, and that's to have a quick look at the causes and risk factors of hypoglycemia, some of the strategies we can use to try and prevent it, methods of glucose monitoring, and some of the advantages and limitations, technology to limit hypoglycemia, strategies to manage impaired awareness of hypoglycemia. That could take an hour, but I'm going to say one slide, and treatment of hypoglycemia. So just if we move on to the next slide, just a brief word about common causes. This is all the sort of medical student stuff, really, I suppose. Although a lot of people don't realize the commonest non-diabetic cause of hypoglycemia is alcohol. And as you all know, insulin is the major problem in hypoglycemia, but we mustn't forget the sulfonylureas and the glycosides. And in fact, if you look at this meta-analysis, looking at all the non-insulin therapies, both the sulfonylureas and the glycosides come way out to one side when it comes to the risk for hypoglycemia. And then the therapy-induced causes are, of course, taking too much insulin, too much sulfonylurea, inadequate food, often exercise, and perhaps taking alcohol without food. So these are all causes, and that's straightforward. We shouldn't confuse these, though, with risk factors. And advancing age is a major cause, particularly, we're talking about type 2 diabetes. I'd emphasize type 1 diabetes is a bit different. There are slightly different risk factors. Aggressive control, of course, intensive therapy will increase the risk. The longer people are on multiple injection therapy with type 2 diabetes, the greater their risk increases. We showed this very nicely in the UK hypoglycemia study, which Simon was the lead on. So we have to be very careful as people, the longer they're on it, they're going to have an increased risk. And again, as we've seen in type 1 diabetes, if they've had previous severe hypoglycemia, they're likely to get it again. So that's a red flag. Recent severe hypoglycemia, impaired awareness, not so common in type 2 diabetes as type 1, but it does occur. And of course, any comorbidity, particularly renal impairment. Some recent interesting studies showing that depression is a risk factor and also cognitive impairment. So these are other things that we have to take in consideration for type 2 diabetes. Now, what strategies can we use then to try and prevent it? Well, education, of course, is fundamental here. We need to discuss it not just with the patient, because the patient sometimes isn't taking it in. There's so many things going on, but also with their relatives. And it's striking how many studies have shown that neither the patient nor the relatives know anything about hypoglycemia. They don't recognize the symptoms, they don't know how to treat it. So this is very important. We have to educate all of them. And also important that they tell us, the people who are trying to provide the care, when they're having hypoglycemia. Now, we looked at the study on this recently in the UK. How often does a patient tell their doctor, or their healthcare provider, or their nurse, clinic nurse, that they're having non-severe hypoglycemia? Not severe, non-severe, straightforward non-severe. And in fact, 3/4 of them never tell them. They never mention it. So there's only a small percentage are actually thinking that this is an important factor that they should tell the healthcare provider about. So that's clearly, there's some major deficiency there. Other strategies, diet and exercise, all fairly common sense. Follow a predictable eating plan, for example. Monitoring blood glucose before and after exercise, you'd think that would be straightforward, but a lot of people just don't bother. And taking a snack, particularly if the exercise is going to be prolonged. And you know, if somebody's had a hypoglycemic event in the past, you'd think that would maybe moderate or change their approach the next time round. So I think we have to emphasize that that's an important factor. Again, one of the fundamental things here in trying to spot hypoglycemia is a potential problem is doing routine monitoring, glucose and medication monitoring. So it's up to us to look at the glucose monitoring data. And a lot of patients complain that they bring their their carefully filled out book with blood glucose results to the clinic, they hand it to the doctor or the nurse there, who just throws it to one side, has a quick glance at it, and doesn't really take any effort to look at this. So that's another important measure. You can spot the people with the impaired awareness of hypoglycemia by the fact that they have a lot of low figures, but seem to have no problem with it, no symptoms. And the other important thing is to check that they're taking the tablets that you think they're on, because quite often, and many studies have shown this, that patient adherence is not good, and they're not actually taking what we think they are. Sometimes this happens when they come into hospital, they actually get put on the tablets, and they start going hypoglycemia then, because they're actually getting the effect. So adherence is important. If they're on sulfonylurea, you can consider changing to a different drug class. If they need an add-on to basal insulin, then think of alternatives to basal insulin, GLP-1 agonists, other potential therapies, SGLT2 inhibitors, and so on. If they're on a basal bolus insulin regimen, then they should be checking their blood glucose before each meal, and we need to consider changing their insulin type. Now, you look at this list and you think, oh, but that's all straightforward. But remember, there are many parts of the world where to get insulin at all is a big problem. It's not readily available. So there are many countries, sub-Saharan Africa and so on, where actually getting insulin is not that easy. So they're all on some of the very, what we would consider very basic insulins like NPH and so on. And you can change these to other potential therapies to try and limit the hypoglycemia risk, and also adjust the insulin in relation to exercise and intercurrent illness. Just interesting to look at the ways of glucose monitoring and the advantages and limitations. Now, most people who are on insulin are doing capillary blood glucose monitoring, which is relatively quick and easy and relatively accurate. But it's painful and it's uncomfortable, it's inconvenient. Everybody sees you do it, and people often miss out, they just forget to do it at all. So, of course, continuous glucose monitoring is now available in some places. It has the advantage of giving a full glucose profile, and it has an alarm system, and you can connect it up to a pump. But it's very expensive, so it's not widely available for many people. And it has to be calibrated, and you have to get somebody who knows what they're doing to interpret it. So again, it's not just a case of, well, here's my results, doctor, have a look at them. You've got to download it, you've got to look at it carefully. And then one of the other things is flash glucose monitoring, which is becoming popular in many countries, particularly in Europe, North America. Advantages, again, full glucose profile. You don't have to calibrate it. It's relatively affordable. Some patients can buy this themselves. It's now becoming available in many countries on prescription, but it doesn't have an alarm system, and you can't connect that up to a pump. So there are various differences there. Oh, technology. Yes, use of technology. Again, you know, go to all the meetings, we hear about all the technology, but of course, again, this is expensive stuff. It does work, though, in that the meta-analysis show that severe hypoglycemia is less than with multiple injections. Significant reduction with continuous glucose monitoring in some studies, not in all. Flash glucose monitoring seems to be beneficial. There's less time spent in the hypoglycemia range. And low glucose suspend feature will reduce nocturnal hypoglycemia. Now, just a quick slide on impaired awareness. It theoretically can be reversed, and the studies have shown this, that you can reverse it or improve it with scrupulous avoidance of hypoglycemia. Extremely difficult to do in routine clinical practice. Obviously, if you avoid or relax control, push the hemoglobin A1C up, often the symptoms will respond to that, return. But a lot of people use defensive eating strategies. They eat frequent snacks, they graze through the day, and that prevents them going low. And they do lots of testing, lots of monitoring. So few patients that I've had who've successfully avoided any severe hypoglycemia, yet have severe impaired awareness, use these two strategies. They eat lots of small snacks, and they do lots of blood testing. And then there are these various psychoeducational programs, many of which are beneficial, but they're quite labor-intensive. and they really need the input from a psychologist. The treatment, pretty straightforward, non-severe. You take oral glucose. I personally have found patients respond quickest to having a glucose drink, but everybody's got their own favorite here. Glucose tablets, sweets of some sort, confectionery, depends where you live, which country you're in, but they all take the same time. That's the problem. And they all take at least 10 to 15 minutes to work. So the problem is, in the meantime, the patient's still getting the symptoms, still feels unwell, and takes too much. And it should be followed by a snack, some starch, complex carbohydrate, and then the severe forms. The gold standard, of course, is to give intravenous glucose. You notice the dose is not that high now. It used to be 50%, 50 grams of IV dextrose. That's not given as far too much, and it gives rebound hyperglycemia. Or glucagon by injection, which is a fiddle and difficult to give, and thankfully there's nasal glucagon on the horizon, which will be given just with a squirt up the nose. So these are the main forms for the severe ones. If the patient's still conscious, then with care, they can be given oral glucose. And this is just finally just to show the therapeutic spectrum of treatment. So you see on one end of the slide, the self-treatment by the patient, and going right up to the other end where they are admitted to hospital in severe hypoglycemia with coma, with a risk of cerebral edema, and may need things like mannitol, dexamethasone, high-flow oxygen, and so on to treat them. So there's a variation, and it depends really on the duration of the hypoglycemia and the severity.